Welcome everyone to today's explainer, Advanced Dermoscopy of Pigmented Lesions, Algorithms, Signs, and Clinical Tricks. Now, if you're a postgraduate dermatology resident, a clinical dermatologist, or maybe a medical educator looking to really sharpen that diagnostic edge, well, you are in exactly the right place. Today, we're taking a deep postgraduate level dive into the advanced dermoscopy of pigmented lesions. We aren't just going to look at pretty pictures, right? We are going to dissect the underlying histopathology, we'll decode the established algorithms, and we'll arm you with evidence-based clinical tricks you can literally take to the bedside today. So get ready to elevate your pattern recognition to that true MD dermatology level.
All right, let's dive right into this. Our agenda today is packed. We're covering 1, the chaos and clues algorithm. 2, dermoscopic metaphors and signs. 3, the Zolodec 4x4x6 rule. 4, acral lesion pattern recognition. 5, diagnostic tests and tricks. And finally, 6, key takeaways and exam pearls.
Starting with Section 1, Chaos and Clues Algorithm, defining the baseline for suspicious lesions.
So, to an experienced dermatoscopist, the vast majority of skin lesions exhibit what we call biological symmetry. Basically, at a cellular histopathology level, this biological symmetry reflects a controlled, totally benign melanocytic proliferation where the nests are neatly organized right along the dermo-epidermal junction. Dermatoscopic chaos, on the other hand, is defined as the presence of asymmetry in any or all of 3 parameters: pattern, color, or border abruptness. Why does this happen? Well, chaos reflects malignant, pagetoid spread of atypical melanocytes. They're ascending irregularly through the epidermis, and they're often accompanied by this chaotic dermal fibroplasia. Honestly, spotting this chaos is the single most compelling red flag during your scan. It's the exact trigger that tells you, okay, we need a formal algorithmic assessment here.
Now, once you do identify chaos, you're actively searching for any of the 9 specific clues to malignancy, things like an eccentric structureless area or maybe polymorphous vessels. If even one is present, you're considering an excision biopsy. And listen up, because this is a massive high-yield point for your board exams, there are 4 critical exceptions where you must consider biopsy even if the lesion lacks chaos completely. Let's break down the why for these. First, any changing lesion on an adult. We flag this because nevi generally stabilize in adulthood, right? So change strongly implies a potential horizontal growth phase melanoma. Second, a small nodular lesion with any clue to malignancy. This accounts for nodular melanomas that grow rapidly in a vertical phase, often entirely bypassing horizontal chaos. Third, any head or neck lesion with pigmented circles or dermatoscopic gray. And fourth, any acral lesion with a parallel ridge pattern. You absolutely need to memorize these exceptions and their underlying rationales.
Let's move to Section 2, Dermoscopic Metaphors and Signs, Visual Anchoring for Complex Pathologies.
Take a look at this classic finding right here. This is the absolute beast sign of melanoma, the blue-white veil. What you're seeing is a confluent, structureless blue pigmentation, and it's overlaid with this white ground glass haze. Clinically, this is highly specific for an invasive melanoma, often pointing to a Breslow thickness greater than 0.75 millimeters. Pathologically, let's break it down. The blue color corresponds to the Tyndall effect. That's created by heavily pigmented melanocytes or melanophages sitting deep in the papillary dermis. Meanwhile, that hazy white veil, that represents hyperkeratosis and compact orthokeratosis, basically a thickened abnormal stratum corneum sitting right on top of it.
Now, what's really fascinating about this slide is how it perfectly illustrates non-melanocytic pathogenesis. This is a basal cell carcinoma. Notice those discrete, bulbous extensions connected at a base, forming what we call maple leaf-like areas. These directly correspond to heavily pigmented aggregates of basaloid cells just branching out along the dermo-epidermal junction. Nearby, those blue-gray ovoid nests represent massive tumor islands sitting much deeper down in the dermis. And here is your quick Viva question pearl for the day. The absolute primary differentiator here from a melanocytic lesion is the complete and total absence of a classic pigment network.
Here's a brilliant little pearl for your everyday clinical differentiation. Under polarized light, you can spot the pore sign in an epidermal cyst. Think back to your etiology. An epidermal cyst is lined by stratified squamous epithelium. This central punctum, the pore side, represents the comedone-like opening of the occluded infundibulum. By using polarized dermoscopy, you bypass that surface light reflection of the skin, which lets you clearly visualize this keratin-filled opening. It's a fantastic way to instantly separate a totally benign cyst from a potentially more worrisome nodule.
And right here, we've got a seborrhea keratosis displaying a brain-like or cerebriform pattern. We really need to explicitly map these macroscopic features to their histopathological realities. Those deep invaginations and grooves, the sulci, they correlate directly to deep, keratin-filled invaginations. Histologically, we know those as pseudohorn cysts. The intervening raised surface ridges, the gyri, they correspond to the acanthosis and papillomatosis that define that robust epidermal hyperplasia you see in a seborrheic keratosis.
Moving on to Section 3, the Zalautic 4x4x6 rule, a structured framework for lesion analysis.
Let's look closely at this table because I want to deeply emphasize how crucial this is. The Zalautic rule acts as a rigorous mental matrix to prevent you from misdiagnosing an atypical melanoma masking as a nevus. It is not just a checklist, it's a highly active cross-referencing system. First, you assess 4 core criteria: color, pattern, pigment distribution, and location. But the real magic happens when you cross-reference those against 6 modifying factors: the patient's age, their skin phototype, their history of UV exposure, pregnancy, growth dynamics, and the anatomic site. For instance, if you see a globular pattern with central pigment distribution in the 10-year-old child, the Zalautic rule tells you, hey, this is a classic, benign, actively growing congenital nevus. However, if you spot a reticular pattern with multifocal irregular pigment distribution in a 65-year-old patient with severe actinic damage and high UV exposure, well, that identical pattern type suddenly shifts to being highly suspicious for melanoma. By forcing yourself to evaluate those 4 morphological pillars directly through the lens of those 6 dynamic patient modifiers, you're guaranteeing an evidence-based evaluation every single time.
Section 4, acro-lesion pattern recognition, navigating volar skin diagnostics.
So, the volar surfaces of the palms and soles present a completely different anatomical architecture, mostly dictated by dermatoglyphics. Let's really look at the underlying postgraduate anatomy here. The skin markings consist of surface ridges and surface furrows. Histologically, beneath the furrows lies the crista profunda limitans. In a benign acral nevus, melanocytic nests are strictly confined to this crista profunda limitans, creating what we call the parallel furrow pattern. Conversely, beneath the raised surface ridges lies the crista profunda intermedia. This is the exact structure through which the sweat duct acrosyringium transverses. In melanoma in situ, atypical melanocytes selectively proliferate along this crista profunda intermedia. The result? Pigment concentrated heavily on the raised ridges, the parallel ridge pattern. Simply put, ridges literally equal red flags, giving you up to a 99% specificity for acral melanoma.
And this brilliantly illustrates how we actually visualize those deep anatomical structures. The physics of acral skin are incredibly challenging. It has a notoriously thick stratum corneum, which causes massive light scattering because of the severe refractive index mismatch between air and dry keratin. Looking on the left, with non-polarized light and no fluid, the deeper epidermal pigment is completely obscured. But on the right, we use polarized light combined with an immersion fluid, like ultrasonographic gel. The gel perfectly matches the refractive index of the skin, completely eliminating the scatter and allowing the polarized light to penetrate all the way down to the dermal-epidermal junction. The parallel architecture just leaps out at you perfectly.
Section 5, diagnostic tests and tricks, hands-on maneuvers for the clinic. Okay, pay close attention, because this is one of the most notorious diagnostic pitfalls in all of dermatology, the subcorneal hematoma. Often resulting from trauma, think sports-related injuries like talon noir, up to 40% of acrohematomas will actually exhibit a parallel ridge pattern. Why? Because the extravasated blood pools in the intracorneal layer and migrates upward right into the ridges of the stratum corneum, literally perfectly mimicking the most dangerous sign of acromelanoma. So how do you differentiate and avoid putting your patient through a painful, totally unnecessary acrobiopsy? You perform the scraping test. As you can see on the right, by gently paring down the stratum corneum with the scalpel blade, you physically remove the intracorneal clotted blood. A true melanocytic lesion resides much deeper at the dermo-epidermal junction and will remain visible, but a hematoma, it will be completely scraped away.
Another beautifully elegant bedside trick is the ink furrow test. If you're ever struggling to map the anatomy, simply take a surgical pen, apply ink over the lesion, and then wipe the surface with a cotton swab. The ink is wiped off the raised ridges but remains trapped deep down in the furrows. Anatomically speaking, this trapped ink perfectly aligns with the crista profunda limitans. If the melanin pigment coincides with that trapped ink, you can confidently say you have a benign parallel furrow pattern. Here is a workflow tip that is absolutely vital. Before your patient goes to the OR, photograph the wider anatomical area and mark the lesion. Consider patients with familial atypical multiple mole melanoma, or FAMMM syndrome. They can have dozens of severely dysplastic nevi. Once they are draped on a surgical table under those blindingly bright lights, finding the exact ugly duckling you meticulously analyzed with the dermatoscope could be extremely difficult. Map it before you cut. You absolutely have to ensure you avoid the medical, legal, and ethical catastrophe of wrong site surgery.
All right, wrapping up with Section 6. Key takeaways and exam pearls, consolidating advanced dermoscopy concepts.
Let's rapidly recapitulate the high-yield Viva points from today's explainer. First, biological asymmetry, so chaos in pattern, color, or border is your primary trigger for algorithmic biopsy consideration. Second, remember your strict histopathological correlations. A blue-white veil equals orthokeratosis over deep dermal melanin, while maple leaf areas indicate basaloid nests at the DEJ. Third, never skip the Zolidec modifiers. Always filter morphological patterns through the patient's history. Fourth, on acral skin, remember that deep anatomy. Pigment on the ridges equates to proliferation along the cristae profunda intermedia and is highly specific for melanoma. Finally, use your clinical maneuvers. Scrape those subcorneal hematomas to prove their intracorneal vascular nature, and ink the furrows to definitively map the cristae profunda limitans.
I'm going to leave you with this provocative clinical scenario just to test your algorithmic recall. A patient presents with a 5 mm pigmented lesion on the heel. It exhibits perfect biological symmetry, absolutely no chaos in color, pattern, or border. However, under polarized immersion dermoscopy, it clearly demonstrates a parallel ridge pattern. So what is your immediate next clinical step? Remember those 4 critical exceptions from the chaos includes algorithm we discussed. Because it is an acral lesion with a parallel ridge pattern, the lack of chaos is entirely irrelevant. The correct answer is an immediate excision biopsy. I really hope this explainer deeply sharpens your diagnostic eye and empowers you with the clinical science you need out there on the ward. Keep scoping, keep questioning, and I will see you in the next one.